Thank you everyone for coming to our webinar today on COVID-19 update for vascular anomalies. I have the pleasure of being joined by several of my peers in this field. One is Dr. Craig Johnson, who's the Program Director of the Vascular Anomaly Program at Nemours Children's Hospital, and he is an interventional radiologist. Also, Dr. Megha is here from the Department of Dermatology. She is the Director of the Vascular Anomaly Clinic at the Mayo Clinic. And Dr. Belinda Dickey, who's Director of the Colorectal and Pelvic Malformation Clinic here at Boston Children's Hospital, but also is part of our Vascular Anomaly Center at Boston Children's. My name is Denise Adams, and I'm a co-director of the Vascular Anomaly Center at Boston Children's Hospital. I want to first, before we begin, talk about several disclaimers. And the first is that we are by no means experts. We are not virologists that study viruses in great detail, nor are we infectious disease experts. All of us are medical providers that care for vascular anomaly patients and are trying to learn as much as we can about COVID-19 so we can better care for our patients. I want you also to remember that information is changing daily, so please remain updated on all this information, as some of it is out of date as new information comes to light. And most importantly, if you have questions, it is really imperative that you speak with your medical providers. This virus is different than the other coronaviruses. So coronavirus in general is an RNA virus characterized by club-like spikes that project from its surface, and that's the pictures that you have all been seeing on the news of this virus. There are several different types of human coronaviruses that cause severe symptoms, and you might be familiar with the terms MERS or SARS. This virus, this present virus, is a novel virus, and the virus is called 219nCoV. That virus causes coronavirus disease 2019, or abbreviated COVID-19. This virus and these coronaviruses emerged from an animal source, and the virus was first identified in an outbreak in China. All of these viruses cause respiratory spread from person to person. So how in more detail is this virus spread? So as I just said, it's spread from person to person. It's spread by respiratory droplets. So every time someone coughs and someone sneezes, their respiratory droplets can be in the air, or they can land on another person, or they can land on a counter and be spread that way. Also, this virus has airborne particles that can stay in the air for about 3 hours, and that's different than some of the other coronaviruses. So if someone goes into an elevator after someone coughs and there are particles in the air, they could get the virus that way. If someone comes into a room and puts their hands on a surface of an object and then takes their hands like from a handshake or a doorknob or a countertop and touches their nose or eyes or mouth, they can also get the virus that way. So some of the symptoms of coronavirus or COVID-19, the most common are fever, dry cough, shortness of breath, and sometimes muscle achiness. Other symptoms that you have to think about are sore throat, headaches, and loss of the sensation of smell or taste. And I'm sure, unfortunately nowadays, that you probably all know someone that has COVID-19. So I've had several people in my family. I had a sister who had a little cough and a sore throat, and then was having a little bit of some trouble breathing, and this was a couple of months ago. And then all of a sudden she lost her sense of smell and taste, and I'm sure that she probably had COVID-19. We recently had someone that we work with that was tested negative, but she started with a cough and also a fever, and then got very, very significant chest pain, and was tested, and she was negative. And we have to remember that about 10 to 20% now they're saying that the testing is negative. So we all have to be careful, and we know that this person had COVID-19. There also is new information that's out there that about 25% of people can be asymptomatic. So they can be walking around without symptoms, and they shed the virus at very high levels, which is a little different than other viruses. So this is why we're going to talk a little more about social isolation, because that's really important. The other thing to think about is that symptoms for this virus, if you have it, can occur 2 to 14 days after exposure. Influenza, so what we think of as the regular flu, only takes 2 to 3 days for people to have symptoms. So imagine how much exposure, if you've been exposed and it takes you 14 days to actually figure out that you have it. Think of all the people that you've been in contact with that you could have exposed to COVID-19, and that's why this is so significant. So how can we protect ourselves and how can we protect others? So this whole thing, we know that this has been incredibly hard, this social distancing, but it is incredibly important. So social distancing means that you need to not congregate. You need to avoid mass settings. You need to keep distances from people, so 6 feet to 2 meters. And now there are stay-at-home orders in most states for people who are non-essential. And this is very, very important because of some of the other things that I said. So it's very important to please be compliant with what your state and what your other countries are directing you all to do. You all have probably heard this, the flattening of the curve. The social distances makes us flatten the curve. If we don't have social distance, this curve is going to go up and our healthcare systems are going to be way above capacity. And if you see what happened in Italy, and if you are hearing what's happening in New York, that's going to be even worse if we don't have the social distancing. So very, very important. Also, things that you can do are to clean your hands and disinfect when you touch objects. So every time you touch something, you really need to re-clean your hands. Every time and if you think about it, how many times we inadvertently touch our face, you really need a clean hand before you touch your face. You can't go out when you're ill. It's extremely important that if you have a cough that you not go out. Or if you have a cough and you really shouldn't go out, but you need to wear a mask if you're ill. People can't be around other people who are coughing. The best hand washing procedures are to wash underneath the sink with soap and water and to sing any little song and sing it twice, or use an alcohol-based hand sanitizer. Initially, when the CDC guidelines came out, masks were only used for people in the hospital or for sick people, but this probably will be changing. In the best scenario, if everyone could have a mask, that would be best, but the problem is that we need the masks for our healthcare survivors, or healthcare workers who are in the midst of what's going on. So it's very important for our healthcare workers to have these masks. But look and see, because that will probably be changing soon. Please restrict your travel and check travel guidelines. So risk factors are people usually with diseases. So older patients that are greater than 60, people with diabetes, but remember, and just be aware that there's a lot of heterogeneity with this disease. And so even though in China and in the other places, we know that older patients are at higher risk and people with medical conditions, but this is a serious illness. And we've also seen 30-year-olds succumb to serious illness, and also 40-year-olds. So and we don't know why. And that's what Anthony Fauci talked about last night. So how can we relate this really to vascular anomalies? We know that it is variable. We know that people with chronic illnesses like diabetes, with heart conditions, can be more susceptible. And so when you think about people with vascular anomalies, we can think about people that have pleural and pericardial effusions, pulmonary hypertension, other reasons for cardiac dysfunction, perhaps people who have had recurrent pulmonary emboli, people who have lung disease. Again, we talk about the effusions, but also perhaps lymphatic disease in the lung. I also worry about people that perhaps could have pulmonary disease related to bony involvement. So people who have involvement of their ribs, their sternum, their vertebrae, people who have anterior mediastinal disease, those kinds of things. Hypertension is also a risk category, and so that means high blood pressure. And so in summary, it's your health professionals are here to help you, and they really care about your well-being. And it is important to consult, to have consultation with them about any questions that you do have. And a wonderful, wonderful thing to go on is coronavirus disease, or COVID-19, the CDC guidelines, and that's cdc.gov. So thank you for that. And I think we can go for some questions now.
We had people submit questions from all of the different support groups and through many different media. So I'm going to just start reading them sort of randomly, and because there's not really any order to these questions. The first one, I guess, would be a dermatological questions. Are patients who are currently taking a beta blocker for an infantile hemangioma at any higher risk? If yes, what are the recommendations for babies and or caregivers who either present with symptoms or test positive for COVID-19? Now I have to, yeah.
Yeah, I'll take that one. So babies that are taking beta blockers for infantile hemangiomas, just because of the beta blocker itself, most are not at higher risk. The exception would be if there is any congenital heart disease or if there is any lung disease like asthma. If that baby does get COVID-19, that baby could be potentially at higher risk. And so in that situation, I think it would be very important if that baby is already on a beta blocker like propranolol to have a discussion with the doctor regarding, whether or not to continue. It would really depend on the individual situation. So if the danger period or the growth period, if we're beyond that, we might recommend stopping it. If it's at a really critical time of treatment, we might recommend not stopping it if enough precautions are able to be made. It would also depend on the severity of the lung disease and heart disease.
Okay. Our patients, and there are a lot of sirolimus questions, so I'm going to kind of group them together, and I'll start those in a little bit. This one, though, is are infants treated with chemotherapy agents for complex vascular tumors or related syndromes such as KHE or KMPS at risk? And if yes, what are the precautions for them or their caregivers should they present with symptoms and or are diagnosed with the virus? That would be Denise.
I'll take that one, yeah. So that's a loaded question. So KHE patients, so first of all, I don't think of sirolimus as a chemotherapy agent. Sirolimus is a non-proliferative, it's an immunosuppressive agent. But sometimes patients who have KHE are on other chemotherapy agents like vincristine. Vincristine, thank goodness, doesn't usually decrease your white blood cells. So, and they theoretically could be on other chemo agents where you would have, if they were on sirolimus, you'd have the immunosuppression from sirolimus, and you'd have the possibility of a decrease in the white blood cell count that made them more susceptible to infections in general. So patients with KHE are probably at higher risk if they were to get COVID-19. Physicians would know that, and precautions that they would take if they were sick, they would be on these same precautions and be at high alert if the infant or toddler or school-aged child had symptoms, to get them into a physician earlier. One of the things that, again, these are questions that you really need to talk to your specific physician about, but one of the things that I think I worry a little bit about, and I'm going to be very honest with patients that have KHE and other inflammatory, so KHE is sort of an inflammatory tumor. There's a lot of markers that we see that can stimulate lymphatic growth that are inflammatory. And sirolimus is really important for that, to keep that in check, because one of the things that this virus can do is it can cause a cytokine storm. So it can make your body release more of those inflammatory products that actually could make, I think, the KHA, and again, remember, we don't know a lot about the pathophysiology, but I would think that if that happened, it would make a lesion like KHE worse. And so it's incredibly important that someone stay on the medicines that they're on unless their doctor advises them otherwise. Does everyone agree with KHE patients? Do the other physicians agree with that? Okay.
Yeah. Sorry, you were on mute for a little bit, but I agree.
Okay, go on to the next one. I think this one would be a Dr. Dickey question. If we have had surgery postponed, but we cannot do this long term, what do we do if we have to reschedule surgery?
So I think it right now, it's partly the institution's decision, and it's probably statewide decisions too on when surgeries may be rescheduled. Right now, any sort of elective procedure we've had to cancel, but ones that are urgent or emergent, we are able to proceed with them. So it sort of depends on the procedure, and it's going to depend on the institution that you're at. Right now, from at least our institution, we're canceled through until the first week of May. After that, it's sort of almost a week-to-week assessment on how far we have to push this out, and really depends on where the numbers of infections are and how full the hospital is with COVID-19 patients. Because we're a children's hospital, we don't have as many patients, but we also are offloading some of the adult hospitals that don't have COVID-19 patients. So that's why the children's cases are also being canceled.
Okay. The next question would be, what happens to interrupted laser schedules? Does this set treatment back?
So I don't know if Megha wants to answer that one.
Yeah, I can take that one. Yeah, just about I think every single laser case would be considered elective at this point. We certainly are not doing any. It usually doesn't set treatment back too much. It does depend on the indication. If it's for the capillary malformation or port wine portion, it really shouldn't set treatment back too much. If it's more of a ablative laser being done for maybe the cutaneous portion of a lymphatic malformation, temporarily you might experience some changes in symptoms, but there are potentially alternatives that can be done even medically to temporize until laser can be started again. So shouldn't be too big of a long-term problem to delay most of the laser cases. You agree, Dr. Dickey?
Can I ask a question, Megha?
Yeah.
What if it was an ulcerated hemangioma?
Mm-hmm. Yeah, for ulcerated hemangioma, you know, I'd really try everything we could topically or and systemically with topical beta blocker, systemic beta blocker, wound care before having to do laser. And I think most of the time we would be able to control it. It might be a little bit, you know, longer than we would ideally like, but I think if we weigh the risks and the benefits, we should be able to manage most.
Okay. This would be, I guess, Dr. Adams. Let's see, would you address clotting? I've read that there may be some therapeutic advantages to treating COVID-19 patients with tissue plasminogen activator. Is this something that can be used for patients that are already taking anticoagulants?
So the first thing, and I think this goes back to what this virus causes. So it absolutely causes a cytokine storm. It also causes DIC. We don't know about the pathophysiology, like why this happens. So any medicine that people are using when COVID-19 patients are in the hospital is really an individualized patient-to-patient treatment option. Those medicines, we know nothing about them as far as if you use them before, whether it will decrease you from getting the virus or decrease the symptoms of getting the virus. So all of those things are really experimental now, but DIC is something that COVID-19 patients are getting. And that's not really completely answering your question, I don't think, but I would not consider that as a treatment before one was, you know, before someone had the virus. And even right now, that's something that is patient to patient, depending on what the patient's symptoms are. I hope that answered your question.
Okay, Dr. Johnson and I were talking earlier, and he brought up something that was kind of something I had not thought of, and then we actually had that question come in, so I'm going to ask him. You talked about live vaccines earlier. Would you kind of expound on that a little bit? Let's
Sure.
unmute you. There you go.
That is, that's been one of the questions. We've had a couple of calls coming in with what the protocols are for live virus and what to do once we have a virus for COVID or vaccine for COVID, which will obviously be quite some time. But should there be any delay in influenza virus, given the fact that we still have some influenza that's lagging around in addition to the COVID.
Okay. Anybody else? We also have someone who has active vascular lesions in their lungs. And then also I got that question about blood clots in the lungs. If you are currently dealing with like an active PE or you just had a PE that's resolving, how much more significant risk are you at for complications with this virus?
So again, we don't know for sure, but certainly anyone who has pulmonary, cardiopulmonary, I'll say compromise, because sometimes multiple PEs can also give you a little bit of strain depending on the PE on your heart. Some people might have pulmonary hypertension. Puts you in a higher risk category. So certainly patients, you need to be super careful if you fit into that criteria. And those are very important things that if you start having any kind of symptoms and have any questions, you need to talk to your doctor sooner rather than later. You should not sit at home with any symptoms. You need to talk to your doctor sooner.
Okay. Some of the general questions that came in: what conditions, if any, within the vascular anomalies world are considered pre-existing conditions that would cause one to be more susceptible to complications?
That's kind of a I mean, so we talked a little, and I'll talk, and then some other people can talk as well, but we talked a little bit about that in some of the beginning slides. So I think if someone has a vascular malformation that's been very proliferative, right? So if it's growing in an area and they're on medicine to suppress the growth, like, you wouldn't want to stop that medicine all of a sudden now, because again, this virus can really injure the endothelium. Any vascular anomaly that is in the lungs, I think, has a higher risk. And remember, we don't know. This is new for all of us, and so, you know, we're talking about trying to have a registry for any vascular anomaly patient that has COVID-19, and we'll be talking about that over the weekend, because we need to know more, because this isn't gone. This unfortunately is here to stay. Like, this will be under control, but this will probably come back, and we don't know when this will come back, and we need to know. We need to be better prepared. But I worry about people that have any kind of vascular anomaly that's in the lung, any vascular abnormality that's causing issues with the heart. I don't know if people who have large vascular anomalies with overgrowth, again, that are proliferative lesions, would be at higher risk, that their lesion would get worse with this, because we know that sometimes lesions get worse with fever and infection and everything else. And this is a virus that does that, and it does this with a vigor. So I think those are the patients that I worry about. The KHE patients that already have those high cytokine levels, the KLA patients that already have those high proliferative cytokine levels, might be at increased risk. And that's why, again, I can't stress the importance of, if medicine is helping you, you can't just stop that medicine. You really need to talk to your physicians about it. Does anyone else have any in regards to that?
I think the only other group that I've talked to recently that I would be concerned about is if somebody had a history of PEs and embryonic vein clots. I mean, certainly with the lung scarring that can occur and everything, that's a small minority of the patients, but certainly another possibility that we're concerned about for them. And a number of the patients that we have also have concomitant asthma and other underlying lung conditions, and certainly those patients we worry about more also.
And really, just going along with that, anyone that has an underlying coagulopathy too, because that's sort of, this can cause a DIC kind of picture. So you wonder if that's going to be aggravated. And again, we don't know. We don't have the natural history of this virus, but that's another group of patients as well.
Yeah, I would agree with all that too. And the only other group of people that I would add, it's quite rare, but if there's any associated underlying primary immunodeficiency as well, we don't know how this virus might act in that situation.
The same question came in about an interrupted sclero schedule, as did the laser. And what they're basically asking is this going to result in more additional treatments? The need for additional treatments, I think. So evidently there are people that are on a 6-week or 6-month or whatever schedule, and they have had to postpone sclerotherapy.
Right. Yeah, this is certainly, as Belinda was talking to, it's where a lot of the departments are combined. We're all under government ordinances now on declarations for all non-essential or elective procedures to be delayed. For down here in Florida, our peak is supposed to be a little bit later. and therefore we're delayed right now till May 8th, but certainly that's always subject to change as this is such a dynamic environment. Certainly for those with endovenous laser procedures, or those who are concerned about PEs from embryonic veins, certainly what we're recommending is really to maximize compression therapy. Use your compression stocking. Obviously, that can be very difficult for some to do, and that's the best thing. In the meantime, if long-term this is going to lead to any more sclerotherapy procedures, we don't think so, and certainly, hopefully, these can be conservatively managed in the meantime. Obviously, there's a lot going on with information about anti-inflammatories, and a lot of people use those for flares and for painful episodes with both lymphatic malformations and any intralesional clotting within venous malformations. Certainly, the recommendation of the World Health Organization now is that we don't have information to indicate that this will cause worsened lung disease. So avoiding any kind of anti-inflammatory or an Advil, an Aleve, that type of a thing. There is no current data to back that up, even though that has been out in the media quite a bit. And we're going to try to reschedule everything as quickly as possible. And I think a lot of the hospitals, all of the hospitals on this phone have recovery plans in place, or are building recovery plans now after the surge of patients, to try to serve everybody as quickly as possible.
Melanie, can I just make a comment about the Tylenol versus the anti-inflammatory agent? So that came from two studies, and
Wait, you're muted.
that came from two studies, and my mute thing is very sensitive. It came from two studies, one from the British Medical Journal, where they were looking, so again, this virus is different. So they were looking at colds, and they were looking at other viral illnesses. And they found that using Advil versus Tylenol prolonged the pulmonary symptoms from the virus. And that's where this whole thing came from. It's interesting though, and this is circumstantial evidence, so it's interesting that it seems that, and I'm going to say this, but we don't have any natural history about this, that inflammation is such a big part of this. So for this particular virus, that might not be the case. And I think that was what Craig was saying. But that's where all of the hype is coming from about not using Advil.
Okay. We had a question about surgeries being postponed. Evidently, we have somebody that had to, what do we do if surgery is needed during this period of containment? Did I get that already? I don't think I did. Yeah, basically they're asking what happens if they have to have surgery. What I think it's that people are nervous that, that they have to have surgery.
I can start out with this. I mean, certainly whether it's interventional procedures or surgeries, what we're doing at our institution is there's definitely many surgeries that need to be performed. Like everything else in medicine, we weigh the risks versus benefits. I think every institution has an urgent protocol. The American College of Surgeons has put out guidelines for what would fit criteria. We have certainly worries about using PPE, the protective equipment. That's very limited supply right now. However, we weigh the risks and benefits of each of those patients. And if there's something that urgently needs to be done, we've looked at that on a case-by-case basis. And every day there's still surgeries being done. Every day there's still some interventional procedures being done. However, we have to look at it in a very different light right now. But definitely don't think if there's an acute appendicitis or something along those lines, and I'll certainly let Belinda add in, don't think that you can't go to the hospital. We just certainly want everybody to think about the risks and benefits, and we have protocols in place for that.
You're muted.
Can you hear me now?
Yes.
Yeah, so I mean, exactly as Craig said, I mean, emergencies are still being done, and urgent cases are still being done, and each hospital, from all the representation I'm sure here, are doing what we're doing, is taking every precaution that we can to bring patients that are not infected. We sort of treat everybody with every precaution to try and prevent any spread of anything, because as many of you know, we don't know sometimes if you come in with it or not. So everybody's almost treated as if you're positive when we come and do a procedure. So if it's a needed surgery, it's going to get done, and it'll be done in the safest way as possible, and to keep everyone else safe too.
I think another important thing is that I think just about every hospital has a telemedicine program right now up and running. And so even if you don't feel like you want to physically go to the hospital, but you feel like an evaluation would be helpful, you know, most hospitals can do that either via video or phone or other electronic means. So don't be shy to request that.
And I think people think that we're closed, but it's not necessarily that we're closed. Everyone is still reachable. I'm sure your providers are still able to give you advice and talk to you. And if it's something that needs to be addressed, it will be addressed.
Okay, along the same lines, should any patient who has received invasive surgery for a complex vascular anomaly be isolated for a specific time following their release from the hospital due to the threat of this virus?
Well, I think I'm assuming they're talking about self-quarantine themselves from everywhere else. Essentially, I think almost every state now is almost in a stay-in-place sort of thing. So on the safe side, yeah, you probably shouldn't be going out and doing the groceries. Have somebody bring the groceries to you, and sort of keeping staying at home, which is what I think everyone else is supposed to be doing. I don't know if anyone else has anything to offer else from that.
No, agree. Everything has been the same precautions and just following the community guidelines that are extremely important right now.
I think I'd be utilizing this as a method of everybody bringing things to me rather than me going out and getting things. There were a lot of general questions, which I'm just going to kind of throw into the same package here. This is related to exposure and high risk, and it really has to do more with who is at higher risk to get complications. Is there any part of the body that is involved that would make you at higher risk? Like if you have a leg versus a chest.
Well,
okay.
I mean, I think now, because this is a pulmonary disorder, so this affects the lungs. Actually, the virus goes into the pneumocytes, which are down by your alveoli, and then it proliferates. So this is a lung problem. Your lungs are they have a lot of interaction with your heart. So I think, you know, the chest, lung, the lung, heart area, to me, is very significant, right? So that would be a high risk. I think it's more important, but that's not to say, you know, because so we know that patients also can have, because of the endothelial damage that it causes, can also have problems with needing dialysis and things like that. So if you have disease in your abdomen that might be around your kidney, or if you have disease in your mesentery that can be proliferative, you know, I think we need to be careful there. And so I think what some of our patients are having a hard time with is, what does that mean? I mean, you know, Belinda talked about, like, everybody is in a stay-at-home kind of situation. And if you are in that high-risk category, you really probably should stay at home. Like the people who are coming back from surgery, like, you should not be the people who are going out and doing the grocery shopping. You know, it's nice to go out and get some fresh air, but you shouldn't be like, you know, my husband was telling me about people playing basketball. Like, that should not be happening anymore. If people are going outside, they need to be keeping the 6 feet away. You know, this whole mask thing comes into play, and, you know, it's who should wear a mask and who should not wear a mask. And as we start to think about this, because again, we need masks for the healthcare providers. But if there is a time that this country has enough masks, it's probably those high-risk patients that might need a mask as they're going out, you know, and being in contact. And then the other question that you have for a high-risk patient is, what happens if you have someone in your family who is a critical worker? So what happens if you have a nurse in your family, right, who is going back and forth to the hospital? And what I've done for some of those high-risk patients, and again, I'm a conservative person, is I've sort of separated them from in the house. So I have made sure that when people, you know, to try to keep them in their rooms separated, and when they're in public places, that people are constantly washing down the countertops, the refrigerator, and the possibility of wearing some protection. So there are many things that are out there that probably would give you some protection. It's not, not everyone needs an N95 mask, but there are many organizations that are making masks for people. You know, so I think those are the people that we have to really think about, what are the extra precautions that we need to do. Does anyone else have anything to add with that? But we've had some of those situations where people are healthcare workers, where people are nurses that are in the same household that are taking care of COVID-19 patients. And just I had a resident that I was on this weekend with that has chosen to not live in his house. He's living in an apartment that a friend has that is not occupied because his friend went to his parents' house, you know. So I think these are things that we need to help our patients and families with, to try to decide what's the best thing for them to do.
Mm-hmm.
Yeah, I mean, I think a lot of essential workers are self-isolating themselves from their family, and I do think that's a very good idea. And just a connection to the, you know, staying 6 feet apart. You know, there was a lot recently about people actually congregating with the intention of staying 6 feet apart. That's actually not social distancing, and so just to be mindful of that as well. Intending to be in the same place as somebody, but 6 feet apart shouldn't happen either.
Okay. Along with that same theme of what is at higher risk, what I'm going to read the things off that people were asking about, and you can kind of like work it into whatever. Parts of the body was one. Diagnosis is another. Age is a third, which we know everybody's 60 and older, but you know, those of us who are 29 forever, we're good. How about the effect of blood thinners on risk? Propranolol was a very frequent comment and question. Sirolimus questions, the dose versus the risk of immunocompromise. Should I lower my dose? Should I stay on the same dose? You know, the patient age versus their amount of compromise. It's kind of the same. They're sort of all the same general questions. And propranolol we've addressed several times. Sirolimus I think we've addressed several times. But if you want to spend a few minutes each talking about that kind of thing, I think that is where the big general questions are coming in to me. And it's coming in from all different diagnoses. So
I think we've talked pretty well about location of involvement. As just something to add to that, if you have a malformation that's just on your chest wall, so it's very superficial, that's not the same as it being, you know, in your lungs, and so that's important. That's, you know, much lower risk, if any, depending on the location. I'll just briefly say about propranolol again. The medication itself for most people does not confer any increased risk. It's really only if there are lung or heart problems. The most common that we're going to encounter in that population is asthma. So that's the one to be most mindful of, but any other chronic lung problems such as, you know, lung disease of prematurity or any congenital heart disease, those are times to just give pause. And it may not mean that you should stop, it just might mean some other precautions.
Okay.
And I guess I'll sort of say this again, because this is really the most important thing. No one should go off of a medicine that they're on without really consulting their physicians, because there's a reason why you were put on that medicine. And we don't know about the pathophysiology of this. You know, it might mean that maybe a little immunosuppressant is good for this. We don't know, and that's a theoretical thing that I throw out there, but there have been some questions about that. So we don't know. We know that there are high-risk patients that have many different diagnoses, the people who are in the hospital a lot, the people who have effusions, the people who flare when they get infections. And again, we're talking about more diffuse lesions. The people who have proliferative processes like KHE, like KLA, that most definitely, I think are at higher risk. Sirolimus can be at high dose, it can be at low dose, but if it's helping your lesion, you really should not go ahead and stop it unless you talk with your providers. We have taken some patients off of sirolimus if we weren't really sure whether the sirolimus was helping or not. But the patients where sirolimus is helping, and that includes all of the medicines, alpelisib, it includes the AKT inhibitor. If that medicine is helping, you really should not come off that medicine. The sirolimus question was even looked at when SARS came around and people had other diagnoses like tuberous sclerosis and like LAM and were put on sirolimus. And it clearly was that your lung function, mostly with LAM patients, will get worse if you are taken off of it. So you really need to talk to your doctor about it. And then the question about the anticoagulation would be the same thing. If you're on anticoagulation to prevent, because you've had a PE or you've had another deep thrombus, you do not want to risk getting another DVT or pulmonary emboli, because that's going to make you at higher risk. These are very important things if you come down with COVID-19, to talk with your physicians, to talk with your physician that's treating you, to tell your physician that's treating you to talk to the vascular anomaly centers that you go to, or even if you don't have, because I know there are some adults out there that might not have a place that they go, ask them to call one of the other centers. If you come down with COVID-19, ask them to call one of the other centers that knows about vascular anomalies for advice.
Okay. One of the other question is, if I were to contract this virus, is there anything that treating physicians need to know?
I think the regular history, I mean, you need to give them to the best of their ability. There's no guarantee that the diagnosis that you carry, the physicians that are caring for you know about that diagnosis, know about the potential complications, sometimes even the medications, but most of them know who to reach out to and where to find that information, and just very, very quickly giving them a complete history of what your underlying history surgically, interventionally, medically is with your disease process. I think that's the most important thing for sure to start out with.
Some people might have portals, and so a portal is a good way for people to go in and get information. Some people might actually carry around a discharge summary or something like that. Whatever they can do to give give people information about them.
Okay. Another frequent topic, or we had several questions on, are babies at less than 12 months, or in some cases less than 18 months at any higher risk? Now, that's not necessarily a vascular anomaly question, but I think that these parents that are already worried about these children that have a little bit of issue, this is scary to them. And I think they don't really, I think it's hard to determine the relation of when to draw that line in the sand and when to be worried, and when to put your baby in a bubble, I guess, or what kind of risk are smaller children at generally in this kind of viral situation.
So in general, that is the best age group, right? So Anthony Fauci in one of his news conferences said we should be looking at all these kids and we should be learning about these kids, because it seems in China and in Italy and in other places they're not as affected, and we need to understand why. That doesn't mean that might not happen though. So I mean, I don't, so that is right now one of the best age groups. But still, if a child, if an infant is having symptoms, they need to talk to their, especially if they have any other underlying condition, they should talk with their physician.
Anybody else? How about patients that have a history of meningitis? Is that history, I mean, it's resolved? So is the history of meningitis significant here?
Not the, well,
I don't think anyone knows.
Not that, I don't think anyone knows, but I mean, I would think that if someone just had a history and they didn't have any long-term effects of that meningitis. Sometimes people can have long-term effects from their meningitis and have brain issues and things like that. But if they had a history and recovered from it, we don't think so. But
This might have
again,
been a GLA patient.
yeah.
I don't know the significance of that. Oh.
Well, GLA patients, if they have bony disease in that area and other things, can have issues with meningitis, and if the person has GLA, which is sort of a proliferative disorder, the GLA in general could get worse. Remember, we don't know the pathophysiology, but we assume that some patients that have different diagnoses will get worse with infection. And I'm worried that maybe that would get worse with infection. And if they have a history of recurrent meningitis, then maybe that would be an issue. Does anyone else want to comment on that?
I think it's just so hard to know. I mean, there's a report, of some neurologic involvement, but it's just hard to know what those relationships are.
I worry about flares. I worry about people's disease flaring with this virus.
Okay. There were also some, I guess there is hope here. People are asking, when they do start to lift this ban of the isolation, would you suggest that this patient group wait a few weeks before they re-engage with society, or should they just follow the normal, social activity that everybody else is doing?
I mean, I think that's going to be hard to predict because it's going to depend on what the landscape looks like at that time. Certainly a lift is coming, and in all reality, there will still be virus around even when the lift comes. And so I think continuing to do the good hand washing, hygiene, staying away from people who might be sneezing or coughing, things like that will be recommended.
Yeah, they've seen recently a little resurgence in Hong Kong with when things were lifted, And then, you know, what happens is, you know, people have been in their houses all the time. They go a little crazy, and now there's there's some more cases of it. So they just need to be careful.
I think a lot of it's common sense too. I mean, if you're not going to go into a big crowded area as soon as the lift is gone, I mean, you'd still, I mean, personally, I probably will still stay away from a lot of those places and do a sort of semi-social distancing if you want to still stay in small groups. And I think a lot of it's going to end up being common sense.
Okay, I have one.
Melanie, I just have another meeting at 4:15, so I'm just looking at.
Oh, okay. Well, then let's make this the last, and then you guys can wrap it up, and we'll go. My son has KLA and is currently inpatient at our local children's hospital. He recently was put on a cyclophosphamide, was added to his regimen of sirolimus and vincristine. Will this put him at any significantly higher risk than before?
So it really depends on how he reacts to that. So I'm sure they're used, so Cytoxan or cyclophosphamide is a chemotherapy agent that can be used in low dose, so sort of this low, not continuous, but sort of a lower, even an oral dose, versus an IV dose at a higher dose. The higher dose can cause someone's white blood cells to drop. So in that way, if the white blood cells drop, you have to worry about bacterial infection. But I would imagine that they're using a lower dose. So I think it would depend on how his body handles that combination of therapy and what his blood counts show and everything else. It's hard to say that he'll be at higher risk. I think he'll be sort of someone at the same risk, but you would be a little more cautious to watch things. But it really depends on how his body tolerates those medicines.
Anybody else have anything else to say here? And I want to thank you very much, and please stay safe for us.
Well, thank you for putting it all together.
Yeah, thank you very much, Melanie.
Agree. Stay safe, everybody.
Mm-hmm.
Earlier, we heard the doctors reference the CDC's position on wearing face masks in public. The same day this QA session was recorded, the CDC updated their recommendation to advise the use of simple cloth face coverings to slow the speed of the virus and to help people who may have the virus and do not know from transmitting it to others. CDC.gov has a simple pattern for a cloth face covering that you can make at home. Note, this change in position on masks is a reflection of the information at cdc.gov being updated in real time. So as new information is uncovered, the site is updated. There is confusing and even some bad information out there, so make sure you keep updated on the latest at cdc.gov. Thank you for tuning in today. Stay safe.